Right. Welcome everyone. Today we're going to be talking about one of my favorite topics. And I think it's very apropos that it's this month. It is Prostate Health Awareness Month. So definitely a discussion about BPH is right front and center along with prostate cancer this month. That's why you'll see us all rocking these very scruffy appearance from No Shave November. The truth is, I look like this most of the year. Okay, couple of housekeeping things before we get started. Let us know if you're having difficulty hearing us. We may just have you come to the front. I know hearing is a little challenging. Also, very important for this group, bathrooms. We got right outside the door here, and there's another one at the other exit. So my name's Scott Quarrier. I'll be talking today with one of my nurse practitioners. Erin and I work together very closely at the University of Rochester. We work in kind of disease-oriented groups. So
more level.
Dr. Rajat Jain formed the Urologist Dr, focusing primarily on enlarged prostates and kidney stones. And we have 3 wonderful nurse practitioners that work very closely with us.
Just to that.
In your visits or combinations of the 2 of us, of 3 of us, it really depends, but we work very closely together. So it works well for this discussion that we're looking. Okay, first, I think we need to focus on what our ultimate goal is. Every patient has a different desire from an interaction. And I think that's important to clarify almost before you walk into the urologist's office. If you ask me what my goal for the visit is, it's not, okay, I want excellent flow. These are uroflow tests. That's a number, means nothing to a patient. But it's a number that says, hey, after this surgery, I was able to pee like a fire hose. But that may be not your goal. Maybe your goal is, okay, I just need some solid sleep. I just need this catheter out. That's all. I need to stop leaking every time I have urgency and I don't make it to the bed. That question is different for every patient. And I want you to think about that before you get to the urologist, because we'll take you down avenues that, you know, may be important to you, but that's not the real reason you're coming to see us. So please, before you see your urologist, really think carefully, what am I trying to get out of this visit? Because I guarantee you, no one wants to be off the chart on a uroflow. Yes, I can get you there. It's great for my research. It's great for my data, but that's not the patient experience. So please, as we go through this process today, think about, okay, that resonates for me because that's what I'm looking to achieve, and it's different for everyone. Today, we're going to be talking about a few different things. Hopefully, the most important is number 4. Hopefully, we have the ability to, with technology, get one of my former patients, current patients rather, former surgical patients, on the phone with us interacting, and we can ask them questions about their patient experience. But first, we're going to talk about what BPH is, and then go into some medical therapy that Erin's going to talk about. We'll talk about some surgical options that we offer here, some that I offer, some that my partners offer, and talk about what may be a reason to choose one treatment over another. Okay, not a new issue at all. Some of the brightest minds have really gone deep into this issue of urinary retention. Benjamin Franklin, not everybody knows Benjamin Franklin, but he actually looked very closely at this. He even had some inventions in the area of urinary drainage. What's super unique about Benjamin Franklin is he actually focused on a part that I didn't even realize people were thinking about back then. Antibiotic-esque catheters. So the silver coiled catheter can't afford that today, I tell you right now. Where I don't prescribe that. But the great thing about it was fantastic from a bacteria perspective. So way ahead of his time. I guess you look back on anything he did in his life, it was ahead of his time. But Dr. Foley is a more recent instance of someone who really changed the field, designed the standard Foley catheter with a balloon at the end that sits in the bladder, and then you don't have to worry about it falling out. And interestingly, this field, some of the most innovative breakthroughs are centered around kind of the stigma behind urinary issues. And I hate that. I wish we could all just accept, hey, y'all, have bladders that need to drain. It is what it is. Some of us have prostates, some of us don't, but we've got to deal with this. So we don't need to conceal catheters in walking sticks. Everybody's seen the golf club bag that one of them's a fake club that you can urinate in it. I mean, we got to get away from that, break free of that mold, and really have honest discussions about, okay, how can I don't think we improved initially. Some of these devices are very scary. I think I'd rather have Benjamin Franklin taking care of me, 100 years before these. But if you look at, these are the devices that urologists, and at that time we may not even have been specialized as urologists, but physicians interested in looking into your bladder were using. The device on the left, only used for women actually, just spread physically the urethra wide open, and then you were able to look at. Horrible torture device if you think about it. But the device 70 years later, I'll tell you, is not that much better. Why? To get light into the bladder, bulbs and electricity, we were not advanced in 1877. That bulb, if it touched the bladder, just to light up the bladder, it would instantly scald the bladder. That was so hot. I don't know which one I would choose. I prefer the catheter from 100 years earlier. From a prostate perspective, where have we come from? Well, this first device in 1909, as scary as the two other devices. This was, think of it as a metal catheter placed in the bladder with no visualization. And they're blindly, because they can't see, taking bites like a hole puncher out of the prostate. Think about the bleeding that occurred after that. Luckily, by the 1920s, we had what any urologist would recognize today as a resectoscope, something that we could apply energy in a controlled fashion, looking in the bladder, and remove the tissue. This is what all of us trained on for TURPs, transurethral resection of the prostate. I guarantee any nurse in the OR would recognize it, be able to put it together. I'd be able to perform a procedure on that. All right. If you want to switch over forgive me. I want to preface, I'm a urologist, I'm a surgeon, I'm not an artist. My mom used to think I was great. That's hysterical to say. So the prostate sits between the bladder back here and the urethra. If we think of the prostate as a donut on its side, the center of that donut is the urethra, and urine comes out from the bladder through the urethra. The prostate, unfortunately, BPH is a growth of that donut into the channel that applies pressure. So when you urinate, the bladder has to get stronger and build up more pressure to get urine out. That leads to many of the symptoms that we all experience, and I'll talk in detail about that. But if we think about what happens when the bladder gets stronger, muscle fibers crisscross around the bladder. The bladder is made up of smooth muscle. Smooth muscle is not the same as skeletal muscle. You don't want the bladder to be strong. Smooth muscle, when it gets too strong, it ends up fibrosing. What that means is it doesn't contract. So you go very quickly from this bladder that's overactive and too strong into a bladder that doesn't contract, and that's a problem. There's some other issues that come up as well, though. The kidneys drain into the bladder. High pressure in the bladder can be transmitted up those tubes, up the ureters, and back up into the kidney and cause kidney issues as well. That's a clear reason, not just to have surgery, but you may go to a urologist and they're going to say, hey, you've got swelling of your kidneys. You've got increasing creatinine. That's the function, the lab that we use to monitor the function of the kidneys. I need to get your bladder drained now. You're leaving here with a catheter. So that's a severe form of this. But there's degrees of that where your kidney function may just be climbing, getting worse and worse. Your bladder may not be emptying, so your residual volume in your bladder is getting bigger and bigger over time. These are all signs that we're not just talking about prostate anymore. We're talking about the bladder being affected, and that's a bad scenario. If we step back and think about the prostate, the first question, rightfully so, prostate cancer is something we all hear about, is an enlarged prostate? No. I hesitate here because the pathology behind a prostate, what makes the prostate enlarged, is not cancer. That's just enlarging glands and proliferation of multiple glands being formed in the prostate. That's benign. That's not going to spread to the bone or anything like that. However, something that we need to discuss is prostate cancer is found increasingly in patients as we age. So if we remove tissue for any reason of the prostate and we look at it under the microscope, we may find prostate cancer. It's not what's causing the inability to urinate. It's not what's making the prostate get bigger and bigger, but it may exist there. They're two separate issues, but they may overlap. They may be present. So when I look at pathology specimens from my patients who have had surgery for BPH, around 4% of them incidentally find prostate cancer. Usually, we don't have to do anything about that because usually it's very indolent, slow-growing form of prostate cancer. We're not doing the surgery for prostate cancer. We just may get a diagnosis of it. That being said, that does tie into some of the workup we do beforehand to figure out, if we need to be thinking, hey, this may be prostate cancer. So we routinely check PSAs in patients who have enlarged prostates. You may be told you need an MRI. There's a whole bunch of avenues that we may go down while we're working up the enlarged prostate. Other things I want to touch on that are happening at the same time as the prostate's enlarging, as we're getting older, as the bladder is decompensating. There is a muscle that keeps urine in. That's called the sphincter, the urinary sphincter. Unfortunately, because the prostate is doing such a good job obstructing the urethra, stopping urine flowing out, that muscle doesn't feel the normal stimulus to get stronger and stronger. You're not sitting there saying, I have to hold urine in order to make it. It's actually usually the opposite. It's, I can't get this urine out. I've got a leak stream. But critically, we need to think about that sphincter, because anything we do to address the problem, the enlarged prostate, we expose that weakened sphincter to the strong bladder muscle. So I want all of you, the one takeaway for everyone is pelvic floor muscle exercises. No matter what you do, whether it's surgery, medical, you name it, your overall health is going to be improved if your pelvic floor health is improved. So I want you to be thinking about, they're called Kegel exercises. Start doing Kegel exercises as long as you don't have a catheter. If you have a catheter, totally different scenario. You should not contract that muscle. I want you to start thinking about doing those as a daily routine, because once you do need surgery, you're going to be much better spot than if you didn't think about your urinary sphincter. The same goes with if it was, say, prostate cancer and you needed a surgery for prostate cancer, what have you, pelvic health is important. Okay. The last kind of thing I want to talk about from what's going on in this process is there's a chance someone may have told you you have a bladder diverticulum. I just want to explain what that is before. A bladder diverticulum is where the lining of the bladder, so if this is the lining of the bladder here, it goes out through the muscle fibers and gets pushed out there because the pressure is too high. And then we're left with a scenario. There's a pocket that has no muscle around it to contract. And we have a very different situation because that area is not going to fully empty on its own without some assistance. We can talk about what to do, but that's one of the scenarios of a bladder getting dysfunction from the prostate enlargement. These are all one and the same. The urgency, the frequency. You may have bladder stones that aren't getting out because the prostate's too enlarged. You may have a bladder that's, you've heard the term maybe atonic bladder or neurogenic bladder or bladder that doesn't contract. That's all related with a few exceptions to a prostate that's obstructing and the bladder has responded inappropriately. Okay. If we can go back to the. So I'm gonna turn it over for a moment to Erin, who's gonna go over some of the medical options for treatment, and we'll switch back to home.
Good evening, everybody. My name's Erin. I'm one of the nurse practitioners working with Dr. Quarrier and Dr. Jane. So I'm going to talk to you about some of the BPH medications. Our first option is the alpha blockers. These medications include the Flomax or tamsulosin, Rapaflo, also known as Silodosin, and Uroxetrel or Alakazocin. These medications work by relaxing the smooth muscles in the prostate and also the bladder neck and the prostate urethra. So what this does is it reduces some of that pressure on the bladder and helps with the flow of urine. So it can help increase stream and also helps with improving the symptoms like the urinary frequency, the urgency, in the nighttime urination. And these medications are great because they do usually work pretty quickly. Like people, usually when we start the medication, people notice a pretty good improvement within like days to weeks of starting the medication. So it's definitely probably like one of the first line medications that we probably use the most for BPH. That brings me to the next medication here. I'm gonna skip the second one here, the 5-alpha reductase inhibitors for a second and go on to the third one here on the list. These are I just call them the PDE5 inhibitors. This because I'm skipping the second one because this one actually also helps relax the smooth muscles of the prostate. So it helps a lot with like the flow of urine and also like the urinary frequency, the urgency. An example of this medication is the tadalafil. Actually, the tadalafil is the only medication in this class that's approved for BPH. So we usually prescribe a low dose, which is 5 milligrams per day. This medication is also known as Cialis. I think most people recognize it by its trade name. It's also used for erectile dysfunction. So in the low dose, it can sometimes have the added benefit of helping with erectile dysfunction. So I'm going to back up to the second one here, the 5-alpha reductase inhibitors. So these medications actually will shrink the prostate over time. They can take a little bit longer to work. Usually people notice an improvement over 6 to 12 months. And this one can actually shrink the prostate by 20 to 25% over that time frame. These ones we don't like as much because they have a lot of side effects. The most unfavorable being the sexual dysfunction or decreased libido. It could cause breast tenderness and enlargement, depression, mood changes. And that medication, the finasteride, also can decrease the PSA level. So we just need to be wary of that. Usually the PSA levels will look like very low, but they actually are probably like much higher. Like, so when we look at that, we usually double the PSA for like tracking. And then, and just backing up a little bit, the other medications like the alpha blockers and the tadalafil, side effects for these are pretty like minimal. They're usually pretty well tolerated. The alpha blockers, usually, the biggest thing is they could drop blood pressure a little bit. So they're better tolerated in the evening, and then also we usually look out for retrograde ejaculation, which means you can lose like forward ejaculation on these medications. And what that means is the ejaculate is just going backwards because it doesn't have that pressure to come out. So it usually just going back into the bladder and pee it out later. And the tadalafil, can also lower blood pressure, and it can cause like flushing, headache. Not everyone gets these side effects, but these are just the most common things that usually come up. And the other thing with tadalafil is like just people with like cardiovascular disease, we have to be careful, especially people who are on nitroglycerin. That's contraindicated in that case, so we wouldn't use it for someone on any like nitrate type medication just because it will lower the blood pressure to like dangerous levels. And then I'm gonna move on to the last medication here, the anticholinergic medications. So these medications actually work on the bladder, they don't work on the prostate. So they're medications that we use for overactive bladder, but they also can help with patients having like very severe like urinary frequency, urgency, leakage. But these medications also come with a lot of side effects. Most serious side effect is sometimes they just work too well and can cause urinary retention. So we usually have to monitor patients very closely on these medications. Like we want to check like bladder scans periodically just to make sure that we're not holding on to too much urine in the bladder. And there's one medication that's not on the list here. There's a medication called Myrbetriq, which is a separate class from the anticholinergics. Sometimes those ones have better side effects. Still can cause urinary retention, but like the other side effects is the dry mouth and the constipation. Sometimes we see people tolerating the Myrbetriq a little better for those reasons. So those are all of the medications. I'm gonna turn it back over to Dr. Quarrier here.
Thank you. So, in general, what is a urologist's role when it comes to medications? Usually, I'd say a patient will come to us already on one medication, which is I think appropriate. You know, for the most part, as Erin said, alpha blockers very well tolerated, and you get a lot of effect for it. Once you start thinking about adding any of the other medications, I think a urologist should be involved. I really don't like to see a patient who's already on anticholinergics just showing up to my office. The problem being that means the bladder is already significantly impacted. I should have been seeing you earlier and intervening before we got to this point where there's a bladder impact. That's scary to me. That's an irreversible process in many respects. Yes, you may get improvement on your urgency with surgery, but there are long-standing changes when it comes to fibrosis that have already taken place that I can't unwind. So alpha blockers, I'm okay with. I like that. Beyond alpha blockers or increasing the dose of alpha blockers, yeah, get a urologist involved, have a discussion at least about surgery.
Doesn't that have to come from your primary care physician?
Depends on your insurance plan. Many insurance plans will allow you to seek specialist advice in the absence of a referral. There definitely are insurance plans that put in a blocker. But if you have a discussion with a primary care physician saying, hey, I would like to see a urologist because this is what I'm experiencing. I think there are very few primary care who wouldn't be opposed to, have a conversation. We talked about some of these indications. These are the indications that were tested on our boards. Hey, you need surgical intervention. But I think you're starting to get the opinion and impression that I'm trying to convey that there are many other reasons to go on to surgery. Acute urinary retention with a catheter. Yes, there are times where you're able to pass a boy trial with just an alpha blocker. If you've been on an alpha blocker and then you go into retention, it's just a matter of time till you go into urinary retention. So I'm thinking surgery almost immediately. Recurrent infections. Two things that are happening here. One, the bladder is retaining urine that isn't able to clear the bacteria. So you're having bacteria that's kind of just sitting in this never emptying location. And also the kind of correlate to that is your prostate itself can get infected. Prostatitis can be a underlying cause of a lot of these sort of things. It also causes the inflammation, proliferation of the prostate tissue, enlargement of the prostate tissue. So infection can not only be a driver of this, but an end result of the prostatic enlargement as well. Failed medical treatment, obvious. Bladder stones. There's no medical therapy that is going to make it so that you clear stones. If you're getting bladder stones, I am sorry, I am going to push you heavily into surgery. It's a matter of time till they come back. A large percentage of my patients, I'm treating the stones at the same time I'm treating the prostate. You gotta treat the underlying cause. The stone is not the issue, it's the symptom. We talked about kidney failure, backing up in the kidney. Yes, we gotta stop it before it gets there. If we're already there, you're going to surgery. Alternatively, there are patients who are not a candidate for surgery, and we may be with renal insufficiency specifically. We may be talking about long-term catheter duration and just management of a catheter. Put that out there because we're not really going to address that today. And then if you're getting clots frequently, we do push you to surgery as well, because that's a treatment for the bleeding. Prostates love blood flow, so they get bigger vessels than anywhere else in the blood. Okay, let's talk about some specifics. This is a surgical therapy I can do in the office that fits some patients, not every patient. Don't get excited to say, hey, this is what I'm going to have. But when we can offer it, it's for smaller prostates, tight bladder necks. We are able to deploy a device in the prostate. We leave it there for 7 days. It causes the prostate to necrose or die off in areas, very specific areas, so that you're left with this wonderful, almost like a Mercedes symbol that keeps the prostate open. It's really a three-prong pressure necrosis is what we call it. But that's really means just dying off in very specific areas. Why I love this procedure. I tend to work, there's many actually implantable stents that are coming on the market. Last I checked, there were like 13 in the pipeline. They only fit certain prostates, but they keep you out of the operating room. I don't understand the utility of a partial treatment if I have to take you to the operating room anyway. This, if it works and I can avoid the operating room, you've just saved yourself from an anesthesia perspective. You've, maybe it's only 5 years, but you're gonna have a better time during those 5 years, than if you didn't have the procedure. Now, all this first class of surgical treatments, these are all, yes, they're temporary implantable devices, but they're also temporary solutions, kind of like medications. I view them that way. They don't have a long-term durable response. You're probably gonna need another surgery down the road. But this sits apart from a lot of the ones I'll talk about, because this I can offer a patient in the office, and that's wonderful. Anesthesia, my wife's an anesthesiologist, that causes side effects. I don't want you to meet her unless you have to. Okay. UroLift. In my mind, UroLift has kind of been replaced by a few of the options. For the patients with the smaller glands, UroLift I believe has been replaced by these implantable devices that you end up removing, because there's a couple downsides with UroLift. So this staples the prostate open. The issues I see with UroLift, it can cause prostatic discomfort. I see that more frequently in these patients. It's almost like a prostatitis picture after, where you just get discomfort down there. You also have to go to the operating room. Why are we doing a temporary solution in the operating room? Previously, we offered this frequently. It was one of the procedures we did the most of, because it had the benefit of preserving for ejaculation. There's another procedure we're going to talk about in a second, does the same thing, actually removes tissue, so you get a more durable response. So in my opinion, this is an opinion, for the most part, UroLift has been replaced on the small side by iTind, or the office procedure, and on the larger side by Aquablation. And we'll talk about them, but this is an option that you may hear about. Resume is kind of looking for its spot. Resume, we inject steam in the prostate and you get necrosis or dying off of prostate tissue. So you do actually get an open cavity. I do think the durability of Resume is probably a little better than UroLift. Some people do offer it in the office. We do have a urologist here who does offer it in the office. It's an involved office visit, unlike the iTinds. It is a uncomfortable even in the office, but you'll get through it. The issue is the first couple weeks, you can go into urinary retention, you can need a catheter for a while, you can have some bleed. Once you get past it, great. And if you can do it in the office, I'm all for it. It is not going anywhere, but I don't see it grow. I think there's a place and a patient for this procedure. I just think we haven't clearly defined which patients benefit most from this. None of these that we've talked about burn any bridges for future procedures as well. So even if they're not the most durable, if you're looking for a few years, they may give you that. Because I can treat a prostate after any of these with no problem. The gold standard, as it were, is the TURP, the transurethral resection of the prostate, where we go in, this is the Roto-Rooter, we go in, surgically resect little strips of tissue from the inside, making that channel wider. I think there's very few places where we should be doing this this day and age. There, I still perform this surgery, don't get me wrong. I still think it has its place. However, aquablation, which we'll talk about, has a computer assisted resection margin. I think that's important because it makes a uniform procedure. TURP, 25 years ago, very different procedure than we do now. It used to be, we go all the way down to the capsule. There's no fluffy prostate tissue to just bounce in like a sponge to that area, filling the space up. We did very aggressive TURPs years ago. That skill, and there's many studies out there looking at it, has been lost. The resections that we currently do are nothing like they used to be. Now, that's good and bad. We saw the issues with the full resection. We're not talking about just retrograde ejaculation, which, as long as you know about it, you can get it from medications, you can get it from surgery. I don't view it as an issue, as long as you know about it and you're accepting of it. But you also, with this, were cauterizing right up into the nerves for the erections, for the sphincter. So you had people who were leaking after these, you had people who couldn't get erections, and you had a lot of bleeding issues. So it was a very, we call morbid, lots of complications from those. So we've got way better at making it a safer procedure, less complications, but it lasts way less because we're not resecting as much. And we can't define the resection margin like the computer can, no matter what you say. Tissue just fills in and then throws us off. So this procedure, I will use it, but it's very selectively. And I think for the most part, there are better options. You heard me talk a lot about aquablation. Where does aquablation fit? We're still seeing that. It's relatively new. I don't want to say it's the newest procedure. The stent I talked about earlier is actually newer than this procedure. But what it does is it uses a water jet. Instead of Resume, which is steam, injected into the prostate, this is a jet. Think of a hole in a submarine. That water is flying through, cutting through whatever gets in its way, steel, you name it. But it stops at a predefined section of the prostate. That has major benefits. We can preserve areas of the prostate so that you have forward ejaculation. I don't like this term sexual dysfunction because I think we need to tease apart the different pieces of sexual dysfunction. This procedure is for preserving ejaculation. That's the benefit. In my mind, this is the temporary procedure. I don't expect long-term durability for the rest of your life. It's got a higher retreatment rate than some of the procedures we're going to talk about in a second. But you get much more durability from this than UroLift, than Resume, than the iTint. So you're talking 5-year retreatment rate around 10%. There is a risk of bleeding. We're getting better at managing this, but it's not insignificant. I never recommend this for patients on blood thinners, even if you can come off of it. Going back on the blood thinners is a problem. When it comes to managing bleeding, the treatments that we talk about are your laser treatments. So photo vaporization of the prostate is called green light by some people. So using a laser to do a very similar thing, or laser enucleation of the prostate. Anticoagulation is a big problem for us. As we age, we have other ailments besides the prostate. There's a lot of patients that are on blood thinners, and we've got to work with that. What I also am nervous about with this procedure and the ones preceding is when we have bladder issues, we're only getting not just a temporary fix, but a partial fix. You preserve ejaculate because you're only partially removing the obstruction. Once we're talking about bladder dysfunction, severe urgency, urgent continence, diverticulum, severe trabeculation, which is those muscle fibers crisscrossing over the bladder that you may have seen on a cystoscopy. Anytime I'm thinking about bladder dysfunction, kidney dysfunction, anything like severe retention, I am steering patients away from surgeries like this to long-term durable procedures because I do not want any progression of what's happening to their bladder, what's happening to their kidneys. Above all else, I can have a Foley catheter in you if your bladder is completely dead. I can't revive a kidney. So I really want to stop that. I do think we want to see this video because I think a lot of patients will choose this. Oh, you have. If we can. So this is the planning process where we use the computer to map out the resected area of that we're going to focus on for the water jet. I want to be very careful to point out what we're not seeing. We're not seeing any of the anterior or the top of the prostate. So that 50% of the prostate is not touched. So automatically, you know, we're not touching any of the top of the prostate. This picture skews, so it looks like we're treating the top of the prostate as well. The urethra goes through the middle. This water jet does not fire up at all. It only fires down. So none of the anterior tissue is removed. That's 50% not removed. The lower, we mark out a butterfly and remove kind of like 2 wings on the side of tissue. And it does a great job of doing that, and it's reproducible. You spend 1 night in the hospital. There is a risk of transfusion. It's not that high. And generally, patients tolerate this very well and have good experiences. Within a few weeks, you're feeling really good. After we do this, we take the scope out and we actually put in that resectoscope, that old-fashioned device that you saw, and we clear off what looks like fronds of tissue. That's kind of the leftover in those areas, and cauterize the bed of the prostate with electrocautery, so you do get some irritation like you would with a TURP, but because it's a defined space, I think it's much more reproducible. It doesn't, one surgeon to the next, you're getting the same thing. So I like this. I send a lot of patients to this as long as they don't have any bladder dysfunction. That's it. So where are we at URMC in terms of aquablation? Well, we started back in October 2023. We currently have 2 surgeons performing this. We're onboarding our 3rd right now. So Dr. Bloom and Dr. Fry are doing this. We've got 176 complete as of yesterday. And I think we're seeing very consistent results from almost immediate. So I think it's a great procedure. Happy to talk to you about it more. What I specialize in is laser enucleation of prostate. It's what I did my fellowship in it. It's what my passion is. It's I go around the country teaching surgeons this procedure. In my mind, it makes the most sense as a surgeon. The prostate is an orange. I am peeling the inside fluffy sponge fruit of that into the bladder, chewing it up with this morcellator device on the far side, and sucking it out. This leaves none of that fluffy tissue behind, so that for your lifetime, not 5 years, not 10 years, your lifetime retreatment rate is 2%. This is as durable as it gets in terms of treatment options. You're also off all your meds. The others, you may still need medication to get the improvement. Medications are off a month after the procedure. Catheter is out 3 days roughly after the procedure. The first couple weeks are not, they're not a cakewalk. Your urgency and your frequency increase because we remove so much, there's all this raw tissue. Think of removing the lining of the inside of your lip. It needs to heal over, so it's irritated for that first portion. And then your urgency and frequency improve. The biggest risk of this surgery is really leakage. I'm exposing that sphincter that we said was weak immediately to the strength of the bladder. So until that bladder relaxes, that sphincter is doing a lot of work. And that's where that prehabilitation, all of you that started doing Kegels just now, that's what gets you through this process. Average patient recovers leakage around 2 to 4 weeks. And you're wearing, even depends initially, so full pads, then you switch to a pad for protection. At 3 months, 10% are still leaking. That's a long time to leak. It actually takes a full year for the bladder to fully relax. So at a year, that number of leaking is around 2%. What is that 2%? Well, we've done a lot of research in this. I'm passionate about education and I'm passionate about research. The biggest predictor is age. The older you are, the more decompensated that sphincter is. The earlier you have the surgery, the better you are from regaining control perspective. Additionally, we're unearthing some neurologic issues we may not have known about. So if you have severe diabetes and you have nerve damage affecting the sphincter that we don't know about because the prostate's doing all, or you have Parkinson's, or you had a spinal injury, something like that, you may still be leaking. It is possible to be leaking without knowing you have any of these at this point pre-surgery. But in my mind, when you have bladder damage, when you have kidney damage, anything that makes us want to just be done with it, get us in the best spot, I want to say it's the most extreme because I'm not cutting on your abdomen. I'm actually going through the urethra with a camera and a laser, peeling that orange, pushing that into the bladder instead of the TURP or the aquablation, which is really come from the inside, not using the anatomy of the prostate to get a clean resection.
Does it have the same blood loss as the aquablation?
So because we're using the laser, it's actually the recommended procedure from a blood loss standpoint. significantly less bleeding than any of the others, with the exception of some of the temporary implants, which may have almost no. But you don't have much effect either. If you wanna switch one. Or you can play it there, that's good, okay. Alright, so this is a video that's showing, this is not me, this is on YouTube, none of my patients end up on YouTube. This is where someone is peeling back the prostate away, and you see there is a plane there, it's separating, just like peeling an orange. That's all I want you to get away from this, is there is a surgical plane that we're just exposing. Everybody has this, and we're utilizing that to peel the orange. Okay.
Does that require anesthesia for doing all that?
So yes, this is general anesthesia. You're asleep for about an hour and a half. Over 50% of our patients now are going home the same day. The others are spending the night either for social reasons, they live far away. I have a lot of patients from Pennsylvania. Or they're having enough bleeding where we want to monitor them overnight. It also can be used on prostate of any size. There are categories of procedures better for this size, better for that size. In general, for aquablation, I'm thinking best under 80 cc's, can go to 120. For the iTind, I'm thinking around 60 cc's or less. Average is 30. For Resume, I'm thinking in the 60 cc range. For a TURP, I'm thinking no larger than 80 cc's. But when it comes to really large glands, this is the procedure. I've done over 560 grams tissue removed from a patient. So this is a procedure that can be used for very large prostates. I've also done 4 cc's tissue. So it can be done with really small prostates. Everybody's got that plane that we're utilizing. It depends on what you're looking for. Anticoagulations, as I mentioned, preferred from a bleeding perspective. Bladder dysfunction, really, we've shown that a patient with proven bladder dysfunction on urodynamics, 97% chance they're going to be able to urinate without a catheter. You know, I've done around 700 of these myself. I think I can think of 2 patients that still have catheters.
What?
Still have catheters of 700. So it does happen, but it's very rare. Workup is unique to the patient. I don't want to say this is what is done. Really depends on the patient. You're coming in with a catheter, we need to get it out. We're moving faster. Really depends. We do want to, the one thing that is standard, we want to try to rule out cancer because we can offer you different surgeries up front. This is where HoLEP fits in the AUA's guidelines, which is my governing body. It's a size independent treatment. They break up their size a little different, large, average, small. Everything fits into kind of its category except for HoLEP. HoLEP can be done for any prostate, and it's especially recommended for patients with high bleeding risk. These are national guidelines. Complications, bleeding, transfusion risk, I actually think it's about 1 in 200 looking at our data. I disagree with the discharge with the catheter less than 5%. As we've switched to going home the same day, I will keep your catheter for 3 days if you go home the same day. We talked about the leakage. There can be abnormal healing. I'm putting big instruments in there. It can be a stricture or scar formation, small amount. You will 100% have retrograde ejaculation. You have to come in knowing that your ejaculate will not come out. It doesn't affect erections, good or bad. I had patients who say, my erections are all due to my prostate, right? It's gonna make it better. No, it won't make erections better, but it's not gonna make them worse. But you gotta know, not have forward ejaculating. You still have orgasms. It's just goes back in your body. So this is where we are. Most recent month is their quarter is lower because we're still in it. So we started performing these in November 2020. There's 1,100 completed as of yesterday. We have currently 3 surgeons performing it. We've got 2 more coming on board. So it's a very high volume procedure because in our opinion, this fits the majority of prostates. I love this procedure. It makes so much sense to remove all the tissue that's going to cause an issue. And do we have? Okay. I was hoping we were going to get the patient experience, but
Oh, wait, yes.
We
he's on
do?
here. Yes,
Okay,
I'm
nice.
sorry, I thought you were asking if anyone had questions.
no. And we
Yes.
Congar, whenever you're ready.
Okay, can you hear me?
yes, we can hear you. Would you mind describing where you were before surgery and where you are now?
Okay, well, I've been seeing Dr. Quarrier for a few years now. And this summer and I was using Flomax and I was doing okay. I kept congratulating Dr. Quarrier on how well he was keeping me. He said, he was sort of quiet. He didn't say too much. I had a gallbladder operation, got a gallbladder removed in June, and that shut down my urinary capability. So I was in an emergency situation. I came in, I was catheterized, and then we did the whole surgery in August, and that has gone very well. It took me, I'm on Eliquis, so we stopped the Eliquis. There was a question about bleeding. It took me about 8 weeks. It calmed down for the first 2 or 3 weeks. There was quite a bit of blood in the urine. That calmed down, but it sort of came back and forth. I think, Dr. Quarrier, you had said that I had a couple of fairly large blood vessels that you thought would, could be a bit of a problem. But all that's stopped. I've had no leakage problem. And the urinary flow is like I'm 20 again. And I've very little pain. I had the general anesthesia and I stayed overnight in the hospital. I live in Geneva down on Seneca Lake. So we stayed the night in the hospital and then I came home. But it's really, it's fixed the problem. And so I have to thank Dr. Quarrier and all his colleagues and the folks who dreamed up this technology because frankly, it's quite amazing.
So what were you looking for? Obviously you had a catheter, but before you had a catheter, what would you have said you wanted to improve about your urination?
Well, as we'd been going through time, my scream was getting weaker and weaker. I have to get up at night several times. I didn't feel like I was emptying my bladder, but I was doing okay. But then because I did the gallbladder surgery, which went through a general anesthetic also, it shut down. So I shut down. I couldn't urinate at all. So then I was in an emergency situation. I got to your office the next day, and put the catheter in. So my desire would be to be able to urinate again, and not to feel, I mean, just to get back to something reasonably normal. That was my goal.
And you're reasonably normal now?
Yeah, I'm better than reasonably normal. I mean, it's, as I said, it's like I'm 21 again.
Excellent. Any questions for him before we go?
I just have one question. Would you have done something different before, if you had to do it all over again? Maybe not stay on Flomax as long, seek surgery?
Are you talking to the microphone? I don't know that you.
Yeah, no, I can hear that okay. Yeah, so would I do something different? Well, I don't think so because I was still able to urinate reasonably well. And we were using the Flomax and that helped. I was hoping that would keep going, but it was because what triggered it was the gallbladder operation, which went very fine. But it shut down my urinary capability. And if I hadn't done the gallbladder operation, I'm not sure I wouldn't just still be, doing what I was doing before. But I think, Dr. Quarrier, you were trying to tell me in a gentle way that the prostate was getting larger and larger, and that at some point in time, we were going to have to do something about it.
Thank you very much for sharing your experience. That's very helpful. Thank you.
Thank you.
All right, I think we're a little behind on timing, so I just want to skip everything that we have left and just jump right to questions, because I don't want to not have an opportunity to answer some questions.
But both you and Erin had mentioned PSA, and I was just wondering if you could give an idea of what's a normal PSA or normal range for someone with BPH.
Yeah, so I'm gonna hold off on answering that directly. In this patient population, in patients with BPH, we have to do some adjustments. So we usually divide the PSA by the volume of the prostate to get a PSA density. So I'm not going to give you strict cutoffs. It also varies by age, but know that the severity of the enlargement due to BPH does change how we view PSA, because normal prostate tissue, that BPH tissue, also produces BPH, or excuse me, PSA. So I'm gonna talk to your urologist one day.
Can you tell us something about the Tulsa procedure?
Truthfully, no. No, there's a lot of interest in this space by industry. BPH is something that the majority of men over a certain age have. So we always have devices that are coming up. And we have devices that just don't take off also. That's where that actually fits. It's not widespread in terms of utilization. I think you can use that as a guide to show you how the rest of the urology community views it, because it's not taking off. Yes.
Okay. Do I understand it correctly that there is no regrowth of the prostate tissue after the HoLEP procedure?
2% lifetime need another procedure. So the prostate tissue we leave behind, this outer peel of the prostate, is a very different makeup. And that's why it separates and peels off. It's much more fibrous. You can get growth, but it's nothing like the rates if you leave any of the inner spongy BPH.
Like with the term.
Correct. So 2% lifetime is what I say, so you can get it. I mean, it's something that happens. I've done, I think 2 redo HoLEPs. That's yes.
I'm pushing 82. And I had an unusual ridge on my prostate. So I sent to a urologist because they took 14 samples and told me that I did not have prostate cancer. Since age 75, I have a physical every year. They've not even done the TRE. They've said that, you know, at your age, you expect to have a swollen prostate. And so I don't know what I'm supposed to be expecting to happen. Do I?
And this is the most common question that I get. And if I can distill it down to the generalization of it. Am I normal? What is normal for my age? Am I okay with this? And that's something I'm gonna just push right back on you. It's all about what you're accepting of. Just because it's the majority of patients that get an enlarged gland, doesn't mean you have to live with the symptoms of it. So I would gauge your symptoms, say, hey, how much is this affecting my life? When I have to go to the bathroom 15 minutes after I just went, when I walk into a new room and the first time I'm out of space, I'm looking, where are the bathrooms? I call that bathroom awareness. When you have that and that radar is on at all times, then you don't need to live your life that way. But if you flip that, you say, is this usual? I'd say yes. Patients, as we age, our prostate gets bigger. But does it mean we have to live like that? No. And that's where it's a very good discussion to start with your urologist. Hey, you know, okay, these are the symptoms I want to get rid of. These are the symptoms I, you know, don't want to develop, like leakage or severe urgency or erectile dysfunction, ejaculatory dysfunction, what have you. Find a place where I can get, you know, is there something I can get both? Just because everybody, you know, has a prostate that grows doesn't mean you have to live with this. Yes.
Yeah, after you do the LAP procedure, do you stop the medications?
Oh, I stopped them 1 month after. I could stop them immediately. The issue is there's some inflammation from the procedure. I just want to get you through that immediate inflammation stage. And then yes, we stop them 1 month off. That's just standard routine. All BPH meds off 1 month after.
We don't need it anymore after that.
Correct.
Okay. Is this available like a printout or something?
We're gonna record it and then they'll get a recording tomorrow.
Yeah, so if you signed up, you'll get a recording tomorrow. We also do have printouts in the office. I don't think we brought any up. We'll see if we can.
Do I need to get?
That'd be great. Yes.
The gentleman who talked about his experience, was lacking a gallbladder. Does did the gallbladder, lack of a gallbladder? Does that impact BPH?
No.
In particular one?
No. So yes, anesthesia, going under anesthesia for any surgery can trigger urinary retention. Very common thing. You may be getting a hip replacement. Your orthopedic doctor may even start Flomax a couple days before the surgery just to prevent that from happening. So that's a common thing that happens after surgery. You know, it's just a triggering event for some. Yes.
I had read about a procedure called Optolume. Is that something that you're keeping an eye on?
So we do Optimum. Everybody has their biases. I think Optimum has a lot of potential for urethral stricture disease. I think it's fantastic. I send patients for that. I send patients for it for other reconstructive issues. I don't like it for the prostate. The prostate is a pretty big organ, but it's very full. There's a lot of stuff in there that's occluding. Optimum, what it does is it blows up a balloon inside the prostate to 90 cc's, which explodes the prostate. That's really what it's doing. It's exploding. And it doesn't care where it's an indiscriminate exploder. It just expands. Their goal is, oh yes, it's gonna separate on the top of the prostate. Not everyone's prostate is that way. Thank you. We can just leave it right there. Yeah. So I've, experienced consultations for patients who it's exploded in ways that we really shouldn't be exploring. The data is positive at this point. It's got some benefits to maybe you don't need anesthesia. I'll tell you right now, everybody's getting anesthesia for it. You're not going to find anyone that does it otherwise because you can get severe bleeding that needs hospitalization from it. This indiscriminate exploding. Maybe not yet. It's not there yet. We're still getting the data. They're pushing it as this in-office procedure. We're not doing it in office. So I'm gonna hold off on final judgment. I can tell you, I don't, as a surgeon who's all about precision, I'm using the anatomy to my benefit. Why am I exploding a balloon in someone's prostate? The nurses or residents or what have you on the floors, when you get your catheter placed first, you may have had a balloon that's only 10 cc's blown up in the prostate in the wrong spot. I'll tell you, it causes problems. That's not a good thing to tell a surgeon you're kind of indiscriminately expanding something. Any other questions?
If is there anything that would preclude, for instance, if you had a TERP and you, after several years, thought you needed, it grew back.
Yep.
Are you still able to do a HoLEP if you wanted to, or is
Yes.
that
Yes. So what I had said previously is none of the earlier procedures stop the ability to do most of the procedures. HoLEP is the catch-all of things gone wrong. So the majority of my patients come to me, I've had this procedure, I've had that procedure, I've had 2 procedures. Fix this. And it's the exact same procedure because I tell you, they don't get anywhere close to what should be resected. So I've done a HoLEP after every procedure out there. Even ones that aren't on the market and that were hot at one point.
After a cystoscopy, the bladder would be normal. What does it mean? No middle lobe. Don't
So
need
there-
surgery.
No middle lobe doesn't mean don't need surgery. There's some I don't know what the urologist was referring to saying don't need surgery, but that's not no middle lobe. There are surgeries that you can't do if you have a median lobe. That's a part of the prostate that sticks up into the bladder and kind of acts like a ball valve closing off that channel. Things like the ITIND you can't do if there's a median lobe. UroLift people say that they can do it, you really shouldn't do UroLift if you haven't made it. That don't need surgery, they may be referring to something else. Maybe the overall size they didn't think was obstructing. I don't know, but it's not just not needed, not having a middle lobe. That's fine.
The alpha, like silodosin, you're on that for say 10 years, and you don't really think that it's changed over that 10 years. Is that some indication of?
Hasn't changed as in I'm maintaining a state where I'm happy, or I'm, they're two different things. So I mean, if it's a state that's not satisfactory to you,
Not
see
sure,
if you're wrong. If you're fine with where you are, yeah, leave it be. If you, on the other hand, if you just want to stop taking medications, you could transition to something like aquablation. If you just want to get off the medication. That's where it's a very personal, and the biggest takeaway from today should be figure out what your goal is and what are the side effects that you can't live with.
And just one follow-up then on the alpha. It relaxes the muscles.
Relaxes the muscles in the prostate and bladder. The things that would make a prostate tighter, it relaxes those.
So would you want to take that in the morning or in the evening?
So we take it at night, because it can, one of the side effects is lightheadedness when you're standing up quickly. So I don't want you to be going from sitting to standing, sitting, standing, things like that at the peaks.
I notice nothing when I take that.
And again, you may, this sounds like a personal, like we should have a real conversation.
How do you get the nephrologist and the urologist to talk to them?
Oh, so depends on who from nephrology and who from urology. Yeah. There are specialties that interact more with nephrology. So Erin and I are in constant communication with nephrology, primarily from our other side, because kidney stone prevention works very closely with nephrology. So we have developed relationships with them. It really depends on the urologist and the nephrologist as well.
They now have a U of R nephrologist and a U of R urologist, so
Excellent.
quickly they're checking.
Yes.
I'm wondering if any of these surgeons here specialize in the iTind procedure?
Yes. Both Dr. Jane and I perform the iTind. Yeah.
Thank you.
Yeah. Anything else?
With the HoLEP procedure and with the removal, does that technically reduce your risk of future prostate cancer?
No.
If it's hereditary,
I
or
can't say
is that?
I can't say this on camera.
Okay, sorry.
So the official answer is you don't have any data to support. I don't think, thinking about where prostate cancer predominantly grows, it's actually in that rind, that peel. So I don't think it reduces that. However, I do think there's a benefit psychologically for patients who have elevated PSA. They're constantly getting biopsies. They're constantly getting MRIs. They're living in this unknown world. Why are we sticking more needles in? To undergo a procedure like this, it's not the primary driver. It's kind of an added benefit of your PSA will drop to 1.2, roughly. That's the average. And then you're not going to be on this, okay, let's get biopsies, let's get MRIs, let's go all crazy. Because it's very stress inducing to be living with an elevated PSA. And that's can be go hand in hand with BPH. So I do think there is a benefit. I don't think it's from a prevention standpoint.
Is there any concern if prostate cancer should develop after you've had the whole procedure to have another
All
procedure.
options are on the table,
Okay.
from radical prostatectomy for cancer to radiation to you name it. So
Thank you.
we kind of gotta wrap it up. So, just anything burning from the questions on the Zoom?
No.
Well, thank you all. Remember, don't shave this month. It's for a cause, not laziness, okay? All right.
Calculus is that.
Yes. Thank you.